Hello, health champions. Today I want to talk about cholesterol because the way it has been understood and managed over the past 50 years may be one of the biggest misunderstandings in modern healthcare. There is a strong fear surrounding cholesterol, and many people who begin improving their lifestyle, losing weight, feeling better, and seeing improvements in most of their health markers are often told by their doctors to abandon those changes simply because one number, LDL cholesterol, is considered too high. This happens largely because we have accepted, without solid evidence, the idea that LDL is automatically bad cholesterol. My goal today is to help you make more informed decisions by understanding what truly matters and what is actually happening inside the body. For many years, if total cholesterol went above 200 or LDL rose above 100, the automatic response was to prescribe statin medication. Statins do reduce cholesterol levels, but we must ask whether lowering cholesterol itself is always beneficial. Do these drugs actually reduce heart disease? Evidence is not as strong as commonly believed, and some research even suggests that higher cholesterol can be associated with lower overall mortality and better cognitive health in later life. While statins do have measurable effects, they can also produce side effects, so why are they still widely prescribed? One reason is the practice of evidence-based medicine, where the primary measurable outcome is whether cholesterol decreases. Another factor is the standard of care, meaning doctors are protected legally if they follow established treatment guidelines. Instead of labeling cholesterol as simply high or low, it is more accurate to think in terms of balance. A cholesterol level of 190 could be unhealthy in one person, while 350 could be acceptable in another, depending on the overall metabolic picture. Cholesterol numbers still provide useful information, but they must be interpreted in context. Rather than focusing only on cholesterol as the cause of heart disease, we should examine the underlying factors. Cholesterol often appears at sites of damage in the body, much like firefighters arrive at the scene of a fire. Their presence does not mean they cause the problem. Similarly, cholesterol is often part of the body's repair process, not necessarily the root cause. The primary contributors to cardiovascular disease are chronic low-grade inflammation, insulin resistance, and oxidative stress. These factors have a much stronger association with heart disease than cholesterol alone. When cholesterol is involved, it is usually because it has been affected by these underlying conditions. To determine whether cholesterol is balanced, we must look at additional indicators such as blood glucose, insulin levels, A1C, triglycerides, HDL levels, and the ratio between total cholesterol and HDL. LDL particle size also plays an important role. Elevated blood glucose typically results from excessive sugar and refined carbohydrate intake, which triggers increased insulin production. Over time, this can lead to insulin resistance, where cells no longer respond effectively. Excess glucose is then converted into triglycerides circulating in the bloodstream. HDL is often considered protective, and the ratio of total cholesterol to HDL provides more meaningful insight than total cholesterol alone. For example, a person may have high total cholesterol but still maintain a moderate risk level depending on their HDL and ratio values. Another useful marker is VLDL, which transports dietary fats to body tissues. When insulin resistance is present, tissues resist receiving these nutrients, causing VLDL to remain in circulation longer and levels to rise. This indicates metabolic imbalance. A key concept that is often overlooked is LDL particle size. Healthy LDL particles are larger and can be efficiently recycled by the liver. However, oxidative stress, inflammation, and glycation can damage LDL, making particles smaller and denser. These damaged particles are harder for the body to clear and are treated as harmful by the immune system. When oxidized LDL damages the inner lining of blood vessels, immune cells called macrophages attempt to remove it. These cells consume the damaged LDL and eventually form foam cells, which contribute to plaque development. This process highlights that inflammation and metabolic dysfunction, not cholesterol alone, drive plaque formation. To emphasize the importance of evaluating the full picture, consider a case where total cholesterol and LDL remained high over several weeks. Despite little change in these numbers, other markers may reveal improvements or risks that are not obvious from cholesterol alone. This patient had already begun making meaningful lifestyle changes, including following a low-carbohydrate, high-fat diet. However, his medical doctor was not impressed. He was strongly advised to start taking a statin drug because, on the surface, his cholesterol numbers did not appear to be improving. To get a clearer picture, We ordered an advanced NMR lipid profile at both testing points. This test measures LDL particle count and size, which provides far more useful information than standard cholesterol numbers. At first glance, the results looked alarming. Ideally, we want the LDL particle count below 1,000, but is measured at 3,448. Now, you may wonder why I'm discussing this case, since the numbers seem concerning. The reason becomes clear when we look at the trend. Over the next 70 days, his LDL particle count dropped from approximately 3,400 to about 2,900, a reduction of roughly 15%. More importantly, the reduction occurred in the most harmful particles. The number of small, dense, oxidized LDL particles, the ones most closely associated with arterial damage, decreased significantly, dropping from 1,653 to 1,227. This is critical because these are the particles that contribute to plaque formation. The test also provides the average LDL particle size, which we want above 20.5. Initially, his value was 20.9, already within the healthier range, and after 70 days it increased further to 21.3. While that increase may seem small, it represents a meaningful shift toward larger, healthier LDL particles. When categorized by pattern, this patient was already in the large particle pattern at the first test and moved further in that direction over time. Another key metric from this test is the insulin resistance score. In January, he ranked in the 57th percentile, meaning more than half the population was metabolically healthier than he was. Just 70 days later, he moved to the 33rd percentile. In practical terms, this means he surpassed roughly 84 million people in metabolic health in a very short period. This illustrates why looking at the full metabolic picture matters. If we had only focused on total cholesterol and LDL values, it would have appeared that no progress was being made. But when we examine particle size, particle type, and insulin resistance, we see substantial improvement and a clear positive direction. Now let's consider statin drugs more carefully. Statins do lower cholesterol, but it's important to understand which cholesterol they actually reduce. Statins work by increasing the number of LDL receptors in the liver, which helps reabsorb LDL particles from the bloodstream. This sounds beneficial, but there's an important limitation. These receptors only recognize and remove large, healthy LDL particles. The small, oxidized LDL particles, the ones we actually want to eliminate, are not affected by statins. As a result, statins lower total cholesterol primarily by reducing beneficial LDL, while leaving the most harmful particles largely unchanged. The only way to reduce oxidized LDL is by improving immune function and lowering oxidative stress, inflammation, and insulin resistance. One argument in favor of statins is that lowering total LDL may reduce the amount available to become oxidized, but a far better approach is to address the root causes directly. Statins also have unintended consequences. They block an enzyme involved in cholesterol production, which also affects the production of CoQ10, a substance essential for energy generation. About 95% of the body's energy production depends on this pathway. When CoQ10 levels drop, overall energy production declines. The tissues most affected are those with the highest energy demands: muscles, the heart, the liver, and the brain. This explains why statins are associated with muscle weakness, fatigue, and muscle damage. The heart, which relies heavily on energy, may be forced to work harder under reduced energy availability. The liver also suffers, as it must compensate for blocked cholesterol production while functioning with less energy. The brain, which makes up only 2% of body weight but consumes roughly 20% of total energy, is also impacted. In short, instead of blocking essential metabolic pathways with medication, a more effective strategy is often to reduce sugar intake, improve insulin sensitivity, lower inflammation, and support the body's natural balance. If you found this discussion helpful, explore the next lesson to gain a deeper understanding of how the body truly works and how to take control of your long-term health. Thanks for watching.